So let's turn our attention to the drug that has come back to us, Gemtuzumab Ozogamicin. It targets not a mutation, but a cell surface marker CD33. Rami?
Sure. So this is an antibody-drug conjugate that has chemotherapy bound to the antibody that targets CD33. In my fellowship, it was approved. We use it for refractory relapse AML all the time, but then it was pulled out of the market. The drug has really very important activity in relapsed APL. That's where we used to want to get the drug back. It came back again in recent studies looking at different dosing, lower dosing, in randomized trials, namely the Alpha 701, showing a survival advantage actually for patients with AML, particularly the good risk. And I think the magnitude is not minimal. The magnitude is meaningful for patients, looking at the range of 20% probably at 5-year survival. So I think that's very meaningful. I think the lesson we learned that many of those antibody drug conjugate has to be done at a lower dose. I think some of the other promising drugs like SGN and other drugs were done at lower doses. So were done at higher doses, sorry. So where do I position Gemtuzumab in practice now? I think in patients that are good risk, I think they had become standard, and I think Mark started talking about that. You want to know if those patients have core binding mutation abnormalities or abnormalities, and you want to add it. In the intermediate, you could argue that there is some benefit, but it's not as the good risk. And in the high risk patients, poor risk, there is really no benefit. There is still some data about using them as single agent in patients not fit for chemotherapy. I think, again, with all the promising agents we have and the toxicity profile and stuff, I don't think it's often used. There was a nice abstract from your group, I think, looking at eliminating anthracyclines and now doing FLAG-GO rather than FLAG-IDA in the core binding, showing actually almost similar results. So back to your point, maybe we're going away completely from anthracyclines.
We use it in high-risk APL.
Yeah,
right.
we use it in high-risk
We've done the intergroup study.
High-risk APL.
Right. We've done the intergroup study at arsenic
plus GEO.
Plus GEO. There are efforts looking at actually CPX351 plus GEO as well, and other studies. But that's where I position it in the setting of the good risk, at least, patients.
So, okay, that all sounds good, but, okay, the trouble with this drug is that it got reapproved in 2017, based on the Alpha 0701 study that used 3 milligrams per meter squared, a lower dose, but fractionating days 1, 4, and 7 with chemotherapy, and the MRC trials, they used 3 milligrams per meter squared on day 1, but if you read the papers, some papers got on day 4.
It's any amount.
Any amount, yeah. If the white count was high. And so I guess my question to the panel is, how do you dose it? Do you give 1 dose? Do you give the 3 doses? What do you do?
We give 1 vial, pretty much. It's
Yes,
a 4.5
1 vial.
milligram vial.
Yeah.
And that's our dose day. We like to get it within 4 days of the induction because that's kind of what.
Yeah, we do it with FLAG-IDA. That's been, and mainly in core binding, and we've kind of used similar to the MRC, 1 dose, 4.5 milligram, just cap it, and usually day 1, but anywhere in the first 5 days is okay.
But for APL, we'll use a larger dose.
Yeah, we use the 9.
risk, yeah.
Right.
Same
Yeah,
thing.
we've had variations in using it. The challenging part for me also was in the consolidation setting, because the alpha consolidated still with anthracycline. You omitted the high dose RSC in the good risk. So sometimes I do kind of still modification in the consolidation setting because I still like to keep a higher dose RSC in the good risk. But again, if to be purist, I think one would pick one of the studies and follow exactly what was done.